Hey, good afternoon. I'm Dr. Scott Worden, the TOS guy. Welcome, everybody. Today we're talking about a subject that is near and dear to my heart. It's my baby. It's the MRI imaging we call vista. Today's topic is all MRIs are not created equal. We're going to talk about why that is, not from a technical point of view. We're not going to go into a lot of the details of what a radiologist would do, but we're going to explain it in terms of what we've already learned about thoracic outlet syndrome. Remember that imaging functions along with the clinical judgment. When your doctor sees you and he or she tries to determine, do you have the disease? And then secondly, what would they need to know to plan treatment, whether it's surgery or conservative therapy? There's still a lot in our field of TOS that's unknown about that. And that's where we believe we contribute a huge amount of additional information with our specialized, advanced, unique vista imaging. So let's talk about some of the issues. The three topics I'll cover will be, what is the current standard of TOS imaging in this country in general? Number two, if we had a perfect imaging test, what would that show? What information would that give us? And number three, how have we at Vanguard Specialty Imaging moved from one closer to two, which would be the perfect world that would help everybody get diagnosed and treated? So let's talk about one. What's the current standard of imaging for TOS patients? Well, as everybody knows, I stay in touch with doctors and patients around the country. And since I'm a little busybody, I'm always asking questions, always trying to learn and make things better. So I get copies of reports that have been performed by radiologists around the country. Radiologists go through a lot of training. There's a lot of awfully smart people I've met, way smarter than me in radiology. And yet there are certain forces that keep these reports not ideal or optimized. So number one, they're always short. Number two, they're really not images or reports based on thoracic outlet syndrome. They're based on the brachial plexus. If you look at the header of a report, it'll say MRI of the right brachial plexus or MRI of the left brachial plexus without contrast, something like that. And then the radiologist will generate 4 or 5 sentences and say, it looks normal to me. Not only do I see this in the reports that I get from other radiologists, which I review, of course, with prior images to see what information we already had or what changes occurred from then until now when we do imaging. But I also hear this from the referring doctors. And I have to say, if radiologists don't pay attention, they should. There's a lot of referring doctors who talk to me and they, even over the phone, you can hear them rolling their eyes. I order an MRI, and what do I get back? The brachial plexus looks normal, and that's it. It's not useful to me. Well, that comes about for a few reasons. One is radiologists don't image this area too often. Most radiologists I know kind of shake their heads and want to get through it as quickly as possible. It is a complex area, and the more I've studied it, the more I've realized how complex and variable it is. In a typical normal person, it's complex, but there's all these known anatomic variations that we have to look out for. And it changes depending on the patient's arm position and neck position. It's complex. So for radiologists who don't put a lot of time into learning it, and it takes a lot of time, they're just looking for something big. They're looking for some abnormality like a mass or some rupture of a part of the brachial plexus. But the second part is that TOS, thoracic outlet syndrome, is not a disease of the brachial plexus. It is a disease of the thoracic outlet, which is extrinsic to the brachial plexus and extrinsic to the blood vessels. So changes in the thoracic outlet, dynamic changes in the arm, extra muscles, tight muscles, these things will affect the brachial plexus, but the disease does not arise from the brachial plexus. And so an MRI of the brachial plexus is not even focused on the correct underlying pathology. And if a radiologist starts out this way, he or she is going to unfortunately be led down the wrong path and not provide that useful information that the referring doctor needs to help make the diagnosis, understand the underlying process, and help make decisions based on those things. Now, a lot of radiologists don't have a lot of experience with TOS. When I went through training, in medical school, we spent no days and no classes on thoracic outlet syndrome. I did training in internal medicine and radiology, and in neither one of those do I remember any significant time being spent on thoracic outlet syndrome. So when people go through training and they leave training, they're comfortable doing what they've been doing all along. If they haven't done thoracic outlet syndrome, they don't have a lot of comfort and they don't have a lot of experience. And as a radiologist, one thing you need is you need to see thousands of normal images so that you start seeing those subtle changes. Now, a big mass is one thing. Anybody can see that. Any radiologist will see that. But TOS, far and away, is a series of small things, subtle things. So if a radiologist isn't comfortable with the normal anatomy and all the variations, he or she is not going to be able to do as good a job as they might otherwise. When you watch a TV show or a YouTube channel and there's somebody who's superb at making rocking chairs, I'll take it for granted. It's not so easy to do. How do you make the runners even and curve just the right way? So there are subtleties in every field of expertise, and you only get through that with experience and with feedback and correction as you go along. So radiologists don't train a lot in thoracic outlet syndrome. I know a lot of radiologists, and I've gone through training myself. It's just not there. And then another part is we're really motivated to read a lot of studies as fast as we can. There's more and more people getting medical care. The reimbursement per study is always going down, and radiologists feel the pressure, like a lot of other doctors, to be more productive, meaning fast in ways that are measurable. Now, making the correct diagnosis and seeing subtleties isn't always measurable. Nonetheless, radiologists, like other fields, have to read fast. We have to be efficient, quote unquote, and fast. That means that a complicated area like the brachial plexus, when you're not prepared for it by training, when you don't see a lot of them because docs may not refer in your city for these images, then how do you get through that fast? You just look for the big things, you get it off your plate, you're done with it. So unfortunately, there's a lot of headwind against a radiologist doing a good job in the current standard of imaging for TOS. Now, I consider myself fortunate, got to break out of that because I was presented with an opportunity to do something really special by some people I really respect. I got to work with them and I got to learn more. A lot of it I had to train myself. We'll get to that a little bit later. Let's go on to the second question, which is, what would a perfect diagnostic imaging test show for patients with thoracic outlet syndrome? Well, I made a list here. I'm just going to read off to you. It'll make sense if you've followed our studies on anatomy, etc. Number one, you'd want to see the spine, because remember, the nerves start in the spinal canal. They start in the spinal cord, which is in the spinal canal. They have to leave the spine through all these little bony holes, and you want to make sure that the nerves are not pinched as they go and they spread out through these holes and they cross into the side of the neck. So you want to see the spine. You want to see all the muscles, because these muscles form the tunnels that those nerves and blood vessels have to pass through. We know there's a lot of variations like extra muscles or abnormal insertions of the muscles or intertwining of the muscles with the brachial plexus. So you need to see the muscles. The perfect study would not only show the macroscopic muscle that we're looking at, like if you stood 3 feet away, but would also show us the microscopic features. Is there scarring in the muscle? Is there inflammation? Are there tiny little bleeds from a car accident? Now, these things we can't see on an MRI scan. No one has yet. But microscopically, people have done studies. They've taken electron microscopes, and they've looked at the neck muscles from people with car accidents and TOS, and they found changes. So a perfect world, we'd see the macroscopic picture and the microscopic picture. We would see the bones. In a perfect study, we'd see all the ligaments. We'd see the lung. We'd see the spinal cord, the nerve roots, and the brachial plexus. And we would see them both macroscopically and functionally. There are some tests. A test is called Diffusion Tensor imaging, which can look at parts of the brain and see how some of the function of the nerve cells is going. But this is not really suitable yet in the brachial plexus, which is much smaller than the brain. And I don't know if it ever will be ready for it, but anything that shows function of the nerves would be valuable in a perfect test. Many of you may have heard of MR Neurography. There's a clinic in Santa Monica, I don't mind mentioning their name, the Neurography Clinic, and they provide a service where they'll isolate the nerves and look at them by themselves. Now, it's a really pretty picture, and a lot of radiologists like to look at it because it's just the nerves. You can accomplish this in a lot of ways. You can do it through their patented method, and you can do it other ways which aren't patented. We been looking at nerves for a while. But there's no real data on how those images relate to disease. If you see an abnormal nerve on one of these neurograms, that's great. That's supportive. It doesn't tell you the cause. It doesn't tell you what's extrinsic to the nerve because everything else is blacked out so you can see the nerve better. But we also know that there are people who have diseases in those nerves and the MR neurogram is negative. There's no data, and I doubt there ever will be, because nobody's going to biopsy the nerves and say, of all the nerves that I biopsied, here are how many showed up as abnormal on MR neurography. So I don't think we're ever going to determine really what the sensitivity of that test is. It's a pretty test, but I don't think it has the answers by itself. In the perfect diagnostic test, it would show every nerve that's abnormal, even on a tiny level. It would show that nerve as being abnormal on the imaging test. I don't think we're at that point or close to it right now. And then we'd also want to see the arteries. In a perfect test, we'd see the veins. And in a perfect test, especially for patients with TOS, we would see what happens when you move your arms. I mean, when you move your arm this way, when you move your arm that way, when you move your arm this way, we would love to be able to see in the perfect imaging test every 5 degrees of motion of your arm. We'd love to see where are you most symptomatic. Some people say, when I brush my hair. And so that would be the best thing. Now, that would be a perfect test, that we can get all kinds of pictures at every possible angle. Okay? That's the perfect what we talked about. Now, let's talk about what I do. At Vanguard Specialty Imaging, we developed and have continued to refine this Nia Vista MRI for TOS patients. Okay? What is it that we do that moves from number 1, the current standard around the country, towards number 2, what the perfect test would show? And believe me, we're not at perfect. Nobody is. And we're not aiming for perfect. But we are aiming to move from 1 to 2 and to keep moving that direction. So what do we do that helps us move that way? Well, part of it is the technique. We have multiple patents. The patents are used to get rid of some artifacts that allow us to do, in one short test, all of the imaging at one time. And that means we can see the spine, we can see the spinal cord and the nerves, we can see the arteries, we can see the veins, we can see the bones, the muscles on a macroscopic level, we can see the ligaments, and we can see some of the dynamic changes. In general, because of the shape of an MRI machine, we'll scan patients with their arms by their side and with their arms about 135 degrees above their head. Those are the 2 positions we can work with. Some people have used an open MRI. There's one study from Canada where they used an open MRI and they got the patient's arms out to the side and they measured a few different angles. Now, the problem with an open MRI machine is that it has lower resolution because it has a weaker magnetic field. And sometimes you need that resolution to see smaller images like ligaments, nerve branches, smaller arterial branches, the insertions of the muscles. So in our opinion, the open MRIs with lower magnetic field and lower resolution are not adequate and clearly not as good as a 1.5 Tesla magnet or a 3 Tesla magnet. Those are the machines, the MRI machines, that you might refer to as high field or closed. And they're the ones that are almost universally available in every major city and smaller cities in the country. So we can image everything that I mentioned in the perfect imaging test. A couple of things we don't get. We can't see the function of the nerves. We can't see when the brachial plexus is abnormal internally on a low or medium level. So patients can have symptoms, which are often intermittent. They put their arms in certain positions. They get the symptoms. Or at the end of a workday, they get symptoms after working really hard, manual labor or a lot of filing, a lot of computer use. Or they sleep in a certain position. So those things are transient and the pain goes up and down. Okay? People have often asked about an EMG, the nerve conduction test and EMG. And those tests in TOS patients are most frequently normal because the whole nerve is not damaged and it's not severely damaged. That's when those tests become positive. We know that patients can have lots of symptoms and those tests don't become positive. especially because you can't put needles in very easily here and probes, and you can't measure where the disease is itself. You have to go farther down the arm and send a really strong signal backwards along the nerve. It reflects through the spinal cord. It comes back down the nerves. It's just a gamish, all right? It's just a big mix-up of signals, and it's very hard to be sensitive in that case. Imagine you take the transatlantic telephone cable, and you got a house in New York City and a house in Paris with a terrible connection. But that cable contains thousands of wires. If you dropped a big sensor from a ship to the middle of the Atlantic Ocean and you sampled that transatlantic cable, you would not be able to separate out that one abnormal signal from all those normal wires, right? If you had 10% of them gone, you probably wouldn't be able to find it. You'd need a lot of those wires to go bad before you'd start getting enough of an abnormal signal. So it's the same thing with the EMGs and nerve conduction velocities. They're not very helpful. And the perfect imaging test would show that, but we don't have that yet. And so we do not see the function of the nerves, but we do see the shape of the nerves, like a neurogram would be, and we can see if the nerves are displaced from their normal pathway. We can see if there's an indentation on the nerve, if it's squished. But in general, we do see lots of abnormal disease without those nerves appearing abnormal by themselves. All right. What else? I think we've covered everything that would be in the perfect imaging test. And the two things we can't show are the functions of the nerves and the microscopic images of the muscles to judge their state. Otherwise, we cover everything on the list, and we do it in one short study with one injection of contrast material. Now, there are some other important things besides creating the images. How are the images interpreted? Now, in the real world, I mentioned that radiologists might not interpret the images with a great deal of detail, and that's because they just don't see them a lot. They don't see what's normal and abnormal nearly as easily as they would for a shoulder MRI or a knee MRI, because they see thousands of those. And after a while, you get better as a radiologist by sheer repetition. You have to read through lots of little motion artifacts, and the patient's anatomy may be different than the next patient, but over time you build up a normal sense. Well, if you haven't done a lot of these, you can't do that with a thoracic outlet. We, fortunately, have a lot of referring doctors who respect what we do and believe it carries value. So we get a lot of studies sent to us. I have read 3,000 or more of these studies. That would be 6,000 thoracic outlets. And so I've seen lots and lots and lots of normals and abnormals. And I'm still learning. But my experience is a big value to the docs who want to understand what's going on inside there. I'll also mention that I am board certified in two specialties, internal medicine and radiology. So I trained first in a clinical field where I deal with patients and symptoms and how to order tests, but I was not an expert radiologist at the time, far from it. So I would take the word of the radiologist and combine that with what he or she said to the findings I had on examining the patient, on what the patient told me. So because I have that skill set, it helps a lot when I'm trying to create new pathways to see what we need to see in you, the patient with TOS. Now, we've also, from Vanguard Specialty Imaging, built up a lot of relationships with doctors around the country, locally, around the country, even some overseas. And that's really important because we get to know, what does a doc need to answer? What does a neurosurgeon in New York, what does she want to see on her images? What does she tell me about her surgery? I've observed many of these surgeries too because of those relationships. I get to see where those docs pick their landmarks, what they're looking for, what they need to know before they go in. It's the same as any other imaging test, really. If someone goes in, someone gets a new diagnosis of a nodule in the lung, we will do a full study of the chest to see if there are any other nodules. We'll see if they're calcified, because that would mean a benign granulomatous disease. The important point of this is that radiologists need to know what the clinician is looking for so they can create the right MRI and they can read the MRI with the important and pertinent findings up front. Now, we have that here at Vanguard Specialty Imaging because we're always picking the brains of our colleagues and we're always understanding what they need to know now and what they need the next month and the next year, because they grow and change also. So, what else can I say? At this point, in review, we have the current state of imaging of TOS patients. In my opinion, It's deficient in many ways in terms of what we really can do when we put our minds to it. Number two, we understand what the perfect imaging test would show. And number three, talk about what our test shows. Part of it's the technique. We've accomplished most of the things on the list of what a perfect imaging test would show, with just a few little things that we don't have right now. Maybe we'll get those in the near future. And the final part of that, in how we're moving from one towards two, is how we continue to learn. We read studies, we follow the research. We've written some ourselves, a new one coming out very shortly. We talk to doctors and patients around the country, and physical therapists, and anybody who's involved with these patients, trying to move knowledge forward. So overall, we have a lot of confidence in what we do. We believe we've earned it because we really care, and perhaps I'm a little obsessive about it, but that's good for you, the TOS patient, because we can really help you. So if anybody has questions, I'd be glad to answer them. If not, I want to remind you that Herb Rep, who manages toseducation.org, has great educational videos from me, from Dr. Tracy Newkirk, from Dr. Art Jenkins, from a lot of other people, Steve Talikowski, physical therapist. At the bottom, you can see that our next live event is 2 weeks from now, and I will be discussing with Tracy Newkirk and Jim Avery a couple of cases to illustrate how we use these imaging tests and the other tests and their clinical examinations to make decisions. Also, please come to my website, tosmri.com. You can go to contacts. It's the last menu on the right. It says news and education, and in there it says contact us. Send us questions or requests. We're glad to help with anything we can. And if we can't help, we're glad to connect you with those doctors or physical therapists or other specialists who can.